Welcome back to my channel. I'm Ramsay Dean, a licensed therapist and social worker. In today's video, we'll explore bipolar disorder and borderline personality disorder. We'll discuss their signs, symptoms, similarities, and important distinctions. I'll also share the most effective treatments for each condition. Stick around until the end to understand why an accurate diagnosis is crucial for successful treatment and why clinicians often misdiagnose borderline personality disorder as bipolar disorder. Whether you or a loved one have been diagnosed with these conditions or you're a clinician seeking better understanding and treatment approaches, this video is for you. Let's dive in. Let's start by understanding bipolar disorder. It's a mood disorder or affective disorder, which means it disrupts emotions. Major depressive disorder, also known as clinical depression, is the most common mood disorder and is characterized by feeling down, hopeless, and lacking interest in life. Now, when it comes to bipolar disorder, the average person might think of mood swings or temperamental behavior. However, this perception of rapid and sudden mood changes doesn't accurately represent the experience of living with bipolar disorder. What does bipolar disorder actually entail? Well, it involves fluctuating between two distinct mood states, depression and either mania or hypomania. Let's delve into this further. People with bipolar disorder experience episodes of major depression characterized by feeling down, hopeless, uninterested in daily life, fatigued, and even having suicidal thoughts. Additionally, they have episodes of mania. It's crucial to understand that these mood episodes, whether depression or mania, last for extended periods, many days, weeks, or even months. Contrary to the misconception, bipolar disorder does not involve rapid mood swings multiple times a day. It's limited to these two moods, depression and mania, with each episode lasting for an extended duration. Let's discuss what mania is in the context of bipolar disorder. Mania is a state of extreme elation characterized by heightened happiness, increased energy levels, decreased need for sleep, rapid thoughts and speech, and reckless behavior. During manic episodes, individuals may engage in impulsive actions such as gambling away their life savings, engaging in promiscuous behavior which is out of character for them, cheating on their partners, or quitting their jobs without a backup plan. It's important to note that impulsivity alone doesn't necessarily indicate mania, as people can be impulsive for various reasons. However, in bipolar mania, the impulsivity exhibited is a significant and drastic departure from the person's usual behavior. In severe cases, manic episodes can lead to psychotic symptoms, including hallucinations, seeing or hearing things that aren't real, and delusional thoughts. I recently listened to a podcast where a clinician shared his personal experience with his sister-in-law who has bipolar disorder. During a manic episode, she exhibited severe sleep deprivation, was pacing throughout the house at all hours, and even had a delusion where she believed she was married to him instead of her sister. This example highlights how mania can cause a complete disconnection from reality and result in harmful consequences. It's crucial to recognize that bipolar mania is a serious condition that can pose dangers to the individual experiencing it. The aftermath of untreated mania can have devastating consequences on personal lives and relationships. It extends beyond simply feeling happy and energetic. It can be a profoundly distressing experience for those affected. Intervention and timely help are essential to mitigate potential harm and provide support during and after manic episodes. Some individuals with bipolar disorder may never experience full-blown mania. Instead, they have what's known as hypomania, which is a milder form of mania. Unlike full-blown mania, hypomania typically doesn't involve psychotic symptoms such as delusions or hallucinations. People with hypomania can often function better and maintain a more stable life compared to those experiencing a full manic episode. When someone with bipolar disorder has a full manic episode, they are often diagnosed with bipolar 1. On the other hand, individuals who only experience the less severe hypomanic episodes are typically diagnosed with bipolar 2. To recap, it's important to remember a couple of key points as we transition to discussing borderline personality disorder. In bipolar disorder, there are two distinct mood states, depression and mania. These mood states typically last for extended periods, spanning days, weeks, or even months. Contrary to common misconceptions, individuals with bipolar disorder do not frequently experience rapid mood swings throughout the day. They only experience the two distinct moods of depression and mania. Stereotypical mood swings involving rapid shifts from sadness to anger to happiness to crying are not representative of the typical presentation of bipolar disorder. It's essential to dispel this myth and misconception. Now let's discuss borderline personality disorder, also referred to as BPD for short. Unlike Unlike bipolar disorder, BPD is not classified as a mood disorder, although it does impact mood, which we'll explore shortly. Instead, BPD falls under the category of cluster B personality disorders. Personality disorders involve significant disturbances in thinking, behavior, and one's perception of the world, leading to serious challenges in various areas of life, including home, school, work, and relationships. Cluster B personality disorders specifically are characterized by intense and unstable emotions, impulsive or dramatic behaviors, and difficulties in interpersonal relationships. In the case of borderline personality disorder, the DSM-5 outlines 9 different symptoms associated with BPD. However, for simplicity, I'll condense these symptoms into 4 broader areas of functional impairment that are easier to grasp. The first area of functional impairment in BPD is unpredictable relationships, which serves as its hallmark. The other 3 areas of life functioning that are affected contribute to this as well, and we'll explore them further shortly. Individuals with BPD deeply desire healthy relationships, but often struggle to maintain them due to self-sabotaging behaviors. This instability in relationships can be attributed to several factors. First, many people with BPD experience chronic feelings of emptiness, a lack of identity, and low self-esteem, causing them to feel lost in life. In an attempt to fill this void, they seek excessive external nurturance and unconditional love and adoration. At the beginning of a new relationship, whether romantic or a friendship, or even with a new authority figure like a boss, things may appear fantastic. They may be enthusiastic, feeling on top of the world, and placing the other person on a pedestal, showering them with praise and admiration. This pattern can also manifest in therapy sessions when clients express similar sentiments early on in the therapeutic process. However, this initial enthusiasm and idealization quickly fades as the person with BPD's high expectations are not met. The other person is unable to fulfill their every need or fill the deep void they feel inside. No matter how much love or adoration is given, it never seems enough. Consequently, individuals with BPD undergo a transformation. They may lash out in confusing ways, push the other person away, and engage in erratic and incongruent behavior. They oscillate between extreme declarations of dependence, "You're everything to me, I can't live without you," and dissatisfaction, "Nothing you do is enough, stay away from me." Another reason for this behavior is the chronic fear of abandonment and a sense of unworthiness of love that many individuals with BPD experience. When their partners, friends, or family fail to meet their every need or provide sufficient love and adoration, they interpret it as an impending abandonment. This triggers simultaneous feelings of terror and rage. Additionally, many people with BPD have an insecure attachment style, often characterized by disorganized attachment resulting from past trauma or abuse. If you're unfamiliar with attachment styles, I have a dedicated video on the topic you can check out. The second area of functional impairment in BPD is characterized by impulsive behavior, which I'll refer to as acting without thinking. Most of us have a built-in mechanism known as brain brakes that helps us pause and consider before acting impulsively when experiencing emotions. However, individuals with BPD have brakes more suitable for a small car, while their emotions resemble a large truck. This mismatch leads them to act impulsively as a way to cope with their overwhelming emotions. Although these behaviors may provide temporary relief, they often result in disastrous consequences in the long run. Common examples of impulsive behavior in BPD include excessive spending or gambling, unsafe sex, reckless driving, binge eating, substance abuse, and self-harm. These impulsive actions further contribute to their unstable relationships as people in their lives struggle to tolerate such behavior. In the context of relationships, individuals with BPD may threaten self-harm or suicide during arguments or uncomfortable interactions. It's important to note that these threats stem from their fear of abandonment and difficulty regulating emotions rather than from manipulation or malice. The intense discomfort they feel overwhelms their rational thinking, and they resort to extreme measures to end the distressing situation. This pattern can also manifest in therapeutic relationships. As a clinician in an emergency room or inpatient psychiatric hospital, I've encountered instances where individuals with BPD threaten suicide during discharge planning. While it may feel like manipulation or control, it's crucial to understand that they are unable to cope with their emotions. Discharging from a hospital signifies the end of the therapeutic relationship, which triggers their fear of abandonment. In the midst of their emotional turmoil, they may act out or make self-harm threats. When faced with such situations, it's essential to remember that their actions are not driven by malice or manipulation. Responding with empathy while maintaining appropriate boundaries is key for clinicians in navigating these challenging moments. The third area of functional impairment in BPD is characterized by volatile emotions. People with BPD often struggle with regulating their emotions effectively, similar to the brain brakes analogy we discussed earlier. Their emotions can be as intense as a Mack truck, but their ability to regulate them is more suited for a Mini Cooper. While the average person might associate mood swings with bipolar disorder, it's actually more common in BPD. Individuals with BPD can experience calmness, rage, despair, and euphoria all within a short span of time, even within the same day or hour. For someone with BPD, anger can arise with little provocation, anxiety can emerge from trivial matters, and despair can be felt even when positive things happen. Their emotions tend to fluctuate rapidly and escalate quickly, but they struggle to bring themselves back to a calm state once their emotions reach a heightened level. Going from 0 to 100 emotionally is easy for them, but returning to a calm baseline becomes challenging. Furthermore, individuals with BPD often have difficulty recognizing and identifying their emotions. Prior to receiving treatment, they may not even be aware of their intense emotional experiences or lack the language to express what they're feeling. As a result, their emotions tend to govern their actions. This difficulty in emotion regulation, known as emotion dysregulation, is a core feature of BPD, alongside unstable relationships. The intertwined nature of volatile emotions and unstable relationships becomes evident as it is challenging to maintain healthy connections with someone who experiences such emotional volatility. As people exit their lives, the fear of abandonment intensifies, the chronic lack of identity deepens, and these factors become intertwined. The fourth and final area of functional impairment commonly seen in BPD is characterized by distorted thoughts. People with BPD have unique thinking patterns that differ from most individuals. Their thinking tends to be extreme, leaning towards all or nothing, black and white perspectives, making it difficult for them to navigate the gray areas of life. They interpret events as either amazing or horrible, view people in their lives as either angels or devils, and perceive their life as either perfect or terrible. In some cases, these distorted thoughts can even veer towards psychosis, where individuals lose touch with reality. They may develop beliefs that others are conspiring against them, or hold onto ideas that are clearly untrue. There may be brief episodes of hallucinations where individuals perceive things that are not actually present. It's important to note that these departures from reality in BPD are typically brief and relatively mild compared to more severe and long-lasting disconnects from reality that are seen in conditions like manic psychotic episodes in bipolar disorder or psychotic disorders such as schizophrenia. Now, let's address why bipolar disorder and BPD are often confused with each other. There are a few reasons for this confusion. First, the names themselves are similar, with a lot of B's, P's, and D's. It's important to note that abbreviating bipolar disorder as BPD is incorrect and can cause confusion. BPD is recognized as borderline personality disorder, not bipolar, so please avoid using BPD as an abbreviation for bipolar disorder, especially in clinical notes. The second reason for the confusion is that both conditions impact mood. However, with bipolar disorder, there are only two distinct moods: depression and mania. These mood states typically last for extended periods, ranging from days to weeks or even months. On the other hand, borderline personality disorder is characterized by impaired mood regulation, poor sense of identity, and unstable relationships. Individuals with BPD experience a broader range of moods, such as anger, sadness, and joy, often fluctuating rapidly. They may exhibit multiple mood shifts within the same day or even the same hour. The third and final reason for the confusion, which often leads to misdiagnosis, is that the impulsivity associated with poor emotion regulation in BPD can be mistaken for mania. In psychiatric settings, during evaluations of individuals who have engaged in self-harm or disclosed impulsive behaviors like risky sex or excessive spending, the time constraints and complexity of the situation can make it challenging to conduct a comprehensive assessment. Clinicians may mistakenly associate the impulsive behavior with a manic episode, and considering a history of self-harm as a sign of depression, assign a diagnosis of bipolar disorder. However, it's crucial to recognize that the mood swings, impulsivity, and sadness observed in these cases are more indicative of borderline personality disorder rather than true mania or hypomania. The core issue lies in emotion regulation rather than mood cycling. counseling. Why does an accurate diagnosis matter for bipolar disorder and borderline personality disorder? Well, the treatment approaches for these conditions differ significantly. I'll provide a brief overview here, but please consult your own healthcare provider for personalized advice. For bipolar disorder, the primary treatment is medication, followed by psychotherapy. Medication, typically a mood stabilizer, is used to reduce the intensity of manic highs and depressive lows. It's the mainstay of bipolar treatment. Psychotherapy can complement medication by helping individuals track their mood, develop coping skills, and make lifestyle changes to minimize the impact of mood episodes. Therapy also assists in recognizing high-risk periods and implementing self-care strategies during those times. However, therapy alone cannot effectively treat the manic and depressive episodes of bipolar disorder. Medication remains the first-line treatment for managing those episodes. On the other hand, borderline personality disorder is primarily treated with psychotherapy. Medication may be considered in specific situations, but it is generally not indicated for BPD without coexisting conditions. Psychotherapy helps individuals with BPD learn emotion regulation skills, curb impulsive behavior, challenge distorted thoughts, and more. Dialectical behavioral therapy, or DBT, is the gold standard treatment for BPD, with extensive research supporting its effectiveness. DBT, developed by Marsha Linehan, who has BPD herself, focuses on emotional identification and applying techniques to manage intense emotions. It also emphasizes interpersonal effectiveness, teaching healthy communication, assertiveness, boundary setting, and conflict resolution. Misdiagnosis can lead to inappropriate treatment. If someone with BPD is misdiagnosed with bipolar disorder and only prescribed medication, their symptoms won't fully resolve. Conversely, if someone with bipolar disorder is misdiagnosed with BPD and receives intensive therapy without mood-stabilizing medication, their manic and depressive episodes may persist. While it's true that we prioritize treating the individual rather than the diagnosis, an accurate diagnosis is crucial for developing an effective treatment plan in the cases of bipolar and BPD. I hope this video has provided you with valuable information and cleared up some misconceptions regarding bipolar disorder and borderline personality disorder. These conditions are distinct and require different treatment approaches. If you're seeking a licensed therapist or need mental health resources, please refer to the video description for helpful links. If you found this video beneficial or are interested in mental health education, consider subscribing to this channel and watching another video. Thank you for watching, and I'll see you in the next one. Goodbye.